let me welcome all of you to Live at Cleveland Clinic. This is a really exciting program tonight. We're going to talk about the new developments in chest wall trauma, which is of particular relevance to all surgeons and particularly trauma surgeons. We have a great lineup tonight, and you are one of several hundred potential people that are joining us from 90 countries across the world. So congratulations. I want to encourage you to use the chat and ask questions. We love questions. And we certainly want to thank our sponsors, Cook Medical, Janssen Biotech, Medtronic, and Olympus Corporation of America. So without any further delay, let me turn it over to Jeff Claridge and his team.
All right. Thank you, Dr. Walsh. Appreciate the introduction, and I agree. This is a very exciting lineup. We're going to talk about chest wall injuries and really focus on rib fixation and how that's evolved. We have 4 acute care surgeons in the U.S. Those are surgeons that a good part of their practice is trauma surgery. So they're going to kind of go through this. We have Dr. Megan Beams, Dr. Jack He, Dr. William Lukart, and Dr. Christopher Wolf, who are all practicing surgeons at our various trauma centers. And I'm going to introduce them before they each part, which this is kind of what we're going to go through. We're going to be pretty good at trying to keep to our time. We have a lot to cover. We're going to start with the history by Dr. Megan Beams, which is going to lead into some of the guidelines, which have literally just been updated this past weekend, hot off the press. And then we're going to talk about some modern fixation techniques, and then get into some of the adjuvant treatment for pain and how to help treat these patients for the pain that goes along with the fractures. And then we're going to really get out there into some of the new technology, and Dr. William Lukart is going to talk about that right after Jack He gives his presentation. Then we'll leave some time for questions, and we do have a case in there at the end. If we get to it, we'll go through that and kind of see what the panel thinks we should do. And at this point in time, I'd like to pull up the first slide, and Dr. Megan Beams will talk about kind of the history and how this evolves. Dr. Beams works at our Level 2 center as the trauma director at Hillcrest Hospital. Dr. Beams.
Yes, good evening, everyone. You should be able to see my slides currently. I'll be going over the history of rib fixation. I'm the Hillcrest Hospital Trauma Medical Director, the Surgical ICU Director, as well as the Director of Critical Care in the East Submarket for Cleveland Clinic. Pleasure to be with you tonight. So I have no conflicts of interest. So we'll first start by talking about the first description of a surgical procedure for rib fractures. That occurred back in the Roman Empire time. So Cyrannus of Ephesus published what you can see below, wrote what you can see below about how he elevated a rib that was broken and irritating or violating the pleural space, and trimmed off the broken fragments at the end. So that is our first documented surgery for a rib fracture. In 1900, there was a publishment of a book called The Treatment of Fractures. This recommended open incision and immobilization of the fracture with suture for those fractures that were comminuted or displaced. And so you can see a sort of a figure of 8 technique used on the rib in the graphic over on the right-hand side. We can also see a more modern picture of how suture can be used for rib fixation. Unusual nowadays to see, but still a technique that can be used occasionally. In the 1920s, there were several attempts at external fixation of rib fractures for flail chest patients. So flail chest is when there's a break in 3 consecutive ribs in 2 or more places. So this really creates like a rib island that is completely separate from the surrounding rib cavity or chest cavity. And so there's paradoxical movement of that island. So every time a patient takes a deep breath in, instead of expanding out like the chest wall normally does, that island sinks down into the chest. And so these attempts at external fixation involved using either bullet forceps or a clothes hanger to grasp around that segment of chest wall that was sinking in to try and keep it immobilized. And traction was used with these devices to maintain that chest wall cavity. The iron lung was also invented in 1927 and became another modality to improve the breathing mechanics of patients with flail chest. Throughout the 1940s, several surgeons mentioned in passing how they wired ribs that were fractured, but it wasn't until the 1950s when Doctors Coleman and Coleman from the Medical College of Virginia published a 15-patient case series in which they described wiring for rib fractures as opposed to using suture, as had historically been done. In the 1960s, Dr. Constantinescu of Bucharest, Romania, developed one of the first rib fracture fixation plates, and you can see a picture of that in the graphic on the right-hand side. In the 1970s, Dr. Paris was the first, he was ahead of his time, he was the first to use a minimally invasive technique for rib fixation. He and his team made 2 small incisions and then inserted a metal plate and secured that metal plate with wire cerclage, or sort of circling of that plate with wire to hold it in place. Dr. Judet also made another advancement in the 1970s. He developed anterior plates that you can see over on the right-hand side. They grasped the anterior part of the rib and used hooks for the top of the rib and the bottom of the rib in order to hold them in place as an attempt to minimize the risk for damage to the underlying lung or pleura during rib fixation. And then we had several physicians who came together in the 1970s to create the first sort of consensus guideline among those 4 physicians, and they strongly recommended operative fixation for flail chest patients because they saw how long their patients were on mechanical ventilation otherwise without surgery. So moving into the 1980s, Dr. Lubitsky also made a breakthrough in using titanium rib plates for the first time. And you'll see in the next slide how much titanium plates have impacted the field. Previously, all plates had been stainless steel, so they were incredibly heavy and very hard for patients to live with long term. And so these titanium plates really revolutionized the field. Dr. William Long also developed a technique for rib plating that involved vertical plating for ribs. This is not the technique that's been carried through to today, but it was a new and groundbreaking technique in the 1980s. And you can see a picture of it here with where the rib plate spans along those broken ribs, almost like a suspension bridge is what it has been compared to. In the late 1980s and into the early 2000s, there was a lot of development, especially among industry, to create low-profile rib-specific flexible titanium plates that were held in place with cortical screws. And you can see an example of that over on the right-hand side. In 1998, VATS was used for the first time in regards to rib fixation. So Dr. Tagawa and his team used VATS along with a mini thoracotomy to fix ribs, and they used absorbable plates for that technique. In 2003, there was a further new technology that was introduced, and that was more of the U-shaped plate that you see there on the right side. In 2003, one of the most landmark papers for this area was released by Tanaka and his team. And this was a prospective randomized trial of severe flail chest patients who were treated with operative fixation. Amongst the operative patients, they had significantly decreased rates of pneumonia, significantly shorter lengths of stay, significantly decreased length or tracheostomy rates. So definitely several significant improvements to their overall outcomes. And you can see their quality of life over on the right-hand side graph. So the S group is a surgical group, and the solid black area is those patients who were able to resume physically active work at the 6-month mark. So there was a sizable proportion of patients who were able to resume physically active work as opposed to in the non-operative group. And so because of this Tanaka study, as well as several other studies published at the same time, the NICE group in the UK published the first guidelines that recommended rib fixation. And you can see that guideline below, that metal rib reinforcements to stabilize flailed chest can show true efficacy in patient care. So it's the first guideline that sort of recommended rib fixation. In 2016, Dr. Pieracci and his group performed the first totally thoracoscopic assisted rib fixation. So definitely another step forward in terms of technology. The Chest Wall Injury Society was formed in 2016, and this group has really formed a great cohort of experts in sort of rib fixation and been at the source of several publications since. One of the most groundbreaking was the non-flail study in 2020, which was, again, another multi-center prospective controlled study in patients with severe non-flail rib fractures. The hope was to see the same sort of improvements we already saw with flail patients in the early 2000s. There were not as many marked differences between the flail patients and between the operative and non-operative patients with non-flail chest, but there were still significant improvements. So you can see in the top graph, it shows the numeric pain score, and that pain score was significantly decreased in the operative group at day 7 and beyond. So definitely a significant impact in terms of pain control in these patients. And then the next graph below that shows the respiratory quality of life scale. At the 14-day mark, there was a significant improvement in respiratory quality of life among patients who had undergone an operation with non-flail chest. And it trended towards significance at the next 2 points. So why are we so interested in rib fractures? So this sort of shows us the state of rib fractures today in the United States. So between 2012 and 2021, the incidence of rib fractures has almost doubled in this country. You can see on the far right-hand graphic, the upper red line represents patients who are 65 years of age or older. And so a lot of the increase in incidence is attributable to that patient population. Unfortunately, it's also these patients who are 65 years and older who are at the highest risk for morbidity and mortality associated with their rib fractures. So within this older patient cohort, mortality increases by 19% for each individual rib that's injured. And then the risk of pneumonia increases by 27%. So because of this increased incidence overall, especially this incidence in older patients, there's been a lot of focus on rib fractures over the past several years. And so I'll hand it over to Dr. Claridge.
Dr. Beams, that was excellent. I guess I have one question as you went through that. You know, in the 90s and around then, I felt like every meeting we went to, there was pushing of different plates, material. Whatever happened to absorbable Vicryl type plates? Did they ever catch on in the literature? I haven't seen them in use for a while. So what are your thoughts?
So they were used mostly in the late 1990s, early 2000s. There was some plate failure associated with them, especially with any ribs that were posteriorly displaced. The absorbable had a hard time keeping those ribs aligned, and so there was early plate failure in a subset of patients. So they are not commonly used today.
Fair enough. Yeah, they kind of just disappeared. You don't see them now. So this is, I think, that takes us to kind of, you know, as we did this, there's basically anywhere from one article in 1992, and you can go back, this slide goes back to, that talks about it. And then I just put those dates up there because in 92, I started medical school. And, you know, you certainly saw rib fractures, but we didn't talk about them that much. And then in 2009, you see kind of this uptick in the literature reporting them. And I think what this means is people were trying all kinds of things up until we get into the 2010s, 2020s, which then take us into kind of where we're going to go next. You know, who should get fixed? How should we fix them? And what are the right patient populations? In other words, what's the best evidence show in the guidelines? And we're going to turn this over now, if you switch slides, to Dr. Chris Wolf. Dr. Wolf joins us from Akron General. He's the trauma medical director there and actually did his residency in the area as well. So it's welcome to have Dr. Wolf. We look forward to your presentation. He's going to take us through both guidelines for fixation and talk about some of the modern fixation techniques. And we're not going to talk about any specific brands, but you can tell if you do this, you'll recognize some of the materials that are out there in the pictures. Those of us that do it can almost recognize who makes what at a time. Dr. Wolf.
Thank you for having me, Dr. Claridge, Dr. Walsh. Appreciate being here to talk about something that I'm passionate about and have a lot of fun doing in my practice. And teaching and sharing our experiences is fun for me. So thanks for having me. I'm going to go through a few things with you guys today. Going for guidelines first. If you go next slide, I'm going to give you an outline of a few different portions of the workup and care for these patients. Disclosures I have listed here. I have no financial disclosures. The only disclosure I wanted to include is that I am in the education committee for the Chest Wall Injury Society. I only wanted to disclose that tonight to say that, first of all, my presentation is going to be excellent because of that. But also, number two is really just to disclose really that I'm very aware of my own biases and my own selection biases. I think that is a very important portion of any physician learning a subspecialty, is to avoid, echo chambers of people that are just going to tell you what you want to hear. I think CWIS has excellent leadership in really following the literature and really trying to do what's best for patients, as the literature shows, and it's the onus of the researchers to demonstrate the benefit rather than the other way around. I went through a lot of articles here to talk to you guys tonight, and I thought this slide was rather funny, just on the nature of how things are presented these days. But next slide. Realistically, we have a relatively short amount of time tonight, and when my initial outline was to give you a really inclusive look at the guidelines across all different societies, not just CWIS, really to try to show that I'm avoiding any biases that may exist. I was lucky enough to see that next slide is new guidelines were posted very recently with the stamp of the American College of Surgeons, produced with efforts through CWIS, but also a stamp from the Osteopathic Trauma Association. You'll see on the next slide the best practice guidelines released just this month. And that is really encompassing the vast area of rib care, going everything from non-operative to operative management. Next slide shows the highlights through this BPG.
And Chris, this just came out this year, like literally this past weekend. This was...
Yes, literally I switched my entire presentation because this came out as I was preparing for this talk. But it's an excellent compendium of all the information, research, and things out there. If you click in, I'll show you just a snippet of what I'm going over tonight in operative management. Next slide, please. I do think that it is worth recognizing another publication by the Chest Wall Injury Society. This is just demonstrating specifically their operative indications and algorithm. Next slide, please. And if you click for the animation of this slide, this paper does focus a little bit more on surgical management, and you can see that we're just going to be covering some of these things here today. The nice thing about this paper is if you get a chance to look, it does give some consensus guidelines through the different authors on which part of these they think were important. And you can see by the 100% through a lot of those columns that they're presenting important and must do things in this paper, which is great. Next slide, please. Just to represent all of the things that we don't get to talk about tonight, not even just me, SSRF, or surgical stabilization of rib fractures, is a valuable adjunct therapy. So we were talking about just a small piece of the puzzle. Next slide. Just to hammer home quickly a couple of things that Dr. Beams introduced for you, again, to show you the data of why this is important. Multiple studies, multiple meta-analyses have been done to really look at the outcomes of these patients. The best data out there, again, as Dr. Beams mentioned, randomized control trials on flailed chest, showing decreased ICU length of stay, hospital length of stay, pneumonia, and mechanical ventilation. And this is seen in systematic reviews that are including more observational trials, not just the randomized control, and then patients not just flail. Next slide, please. And a recent Bayesian meta-analysis also showed with a different statistical analysis that surgical fixation was associated with mitigating most of the commonly researched outcomes with 95% probability. And that's mechanical ventilation, ICU, hospital length of stay, tracheostomy placements, pneumonia, and mortality. Next slide. Authors of studies that I just mentioned had some nice quotes that I wanted to share. Indications require further delineation, but the benefit does not appear to be limited to flail chest. Next slide. And direction of research should shift from whether there's benefit towards a refinement of indications, timing, and technique, which is really going to take me what I'm going to try to focus on today here forward. Next slide. So patient selection, how do we find these patients and who do we select for patients that are appropriate for surgical fixation? Really 3 parameters that I wanted to go over tonight. Starts number 1 with radiographic fractures. Obviously they have to have rib fractures to get a rib fracture surgery. I would argue that the evaluation of these images need to be done by the surgeon themselves to really get the best appreciation of the fracture burden and what potentially can or should be done. Dr. Lucart's going to go into that a little bit more tonight. The other parameters that I want to go into is pain control and pulmonary physiology, as in how do these rib fractures actually affect these patients in their daily life? What is the impact of these fractures? Take one extreme is if you have a patient with several fractures that look like really juicy fractures, really want to fix them. You had the afternoon off, the OR is ready, you really want to go, but they have no pain and no pulmonary derangements. Are you really benefiting that patient? So I would argue in certain sections, you really need to address all parameters, not just pick and choose. Next slide. So how do we do it in our institution? We use the combination of rib score and the SCARF score. This is a combination of 2 predictive scoring tools to look for patients that may benefit, or rather, more specifically, may have complications from rib fractures. Next slide. Why I like this is the rib score is primarily a radiographic score. If you look through this quickly, you'll see some of these factors popping up later when I'm talking about indications, but you're getting a point scale for radiographic rib fracture qualities, as in 1 point for 6 or more rib fractures, bilateral rib fractures, and so on. Next slide. So combine a radiographic evaluation with a physiologic evaluation, which is the SCARF score. And as the article said, together is better. Next slide gives you, if you use a combination of the 2 and say a rib score of greater than equal to 2 and or a SCARF score greater than equal to 3, those are patients that are going to be high risk for complications with rib fractures. In our institution, those scores combined gives you a consultation to our chest wall surgeons, who then have a chance to look at images, look at physiology, and determine next steps. Next slide. This is the CWIS algorithm with some tweaks over the years. This is the most recent version published just last year. Next slide. I like their algorithm because they keep it simple. Speaking of radiographic findings, when you have radiographic findings that will give you chest wall instability, these are the occasions where you may have indications to operate even before looking at physiology. Indications here would be clinical flail. So that's, as Dr. Beam's mentioning, a segment of floating ribs based on multiple fractures. I like to say more than 2 and 2 or more, just because the numbers are easier, and I think people get the numbers mixed up. So more than 2 or 2 or more is a flail segment for me. Clicking or popping usually designates instability in the chest wall and a high indication for pain or non-unions in the future. Significant chest wall deformity, and that's one of those things you know you see it when you see it. Intercostal herniation and rib fractures with internal injuries I have included here with parentheses because those aren't technically unstable, but certainly would give you indications for early operation if seen. Next slide. But from there, anytime you have indications that are not outright radiographic or anatomic needs for surgery, you start to have to combine some of those physiologic factors. And what this algorithm does is it takes you to ventilated patients, yes or no. Those no patients, we're describing a set of injuries. This is primarily driven from that non-flail study that Dr. Beams mentioned. More than three or three ribs with 50% displacement was that cutoff for the study, with pulmonary derangements, so combined with any physiologic changes. Next slide. Or you have patients that are ventilated with a failure to wean due to the rib fractures, if the surgeon thinks the rib fractures are the issue. Typically, again, you're talking on the minimal level of 3 or more rib fractures all the way up to radiographic flail for these patients. And if you think that they're ventilated with inability to wean on multiple attempts, that would be an indication for fixation as well. Next slide. There are some absolute contraindications. Those would be shock or active resuscitation in a sick patient. We're talking about a life-saving operation in the sense of preventing pulmonary morbidity, but in the acute setting, emergency operations or needs obviously take precedent. And other injuries that would make a potential polytrauma patient unsurvivable, such as non-survivable traumatic brain injury, would be a contraindication to surgery for this. Next slide. As far as timing, multiple studies have showed really the earlier the better. As soon as you can get the patient to the operating room, as soon as they're clinically stable, you will see lots of endpoints and time points in the literature. 72 hours is the general benchmark for time to the operating room. You're seeing studies that are going to say earlier and earlier, realistically as soon as you can. Next slide. So key takeaways from indications. Indications is a combined evaluation of radiographic and clinical findings, such as pain or pulmonary derangements. And getting to the OR as soon as clinically possible is going to improve your outcomes. And next slide is going to get me into a little more operative discussion with modern fixation techniques.
Chris, can I pause you there for a second, Dr. Wolf?
Yes.
There's a good question here, and basically, we know it improves pain. Do you have any concrete or better evidence and data on going earlier improves pain by, how do we know that?
You cut out for a second here. The question is earlier time to surgery decreasing pain?
Yeah, so that's one of the benefits, is showing decreased pain. Dr. Beam showed it kind of earlier, and so what are your thoughts on that?
Earlier to surgery is really a question of avoiding some of those compounding physiologic problems with atelectasis and risk of pneumonia and risk of further hospital complications. Pain specifically, you have more inflammation at the ribs. It makes it harder to work. Time to OR is longer, the longer you wait. The time in the OR is what I meant to say. And so I don't think there's outright data that shows pain by earlier OR is better, but other than that, you're affecting other complications with better effect.
Fair enough.
So with modern fixation techniques, again, Dr. Beams took us through the history of the evolution of these constructs. Next slide. Couple objectives for this portion is to give some basic principles of plate fixation and bone healing. I'll show you again some modern systems and some modern approaches. Next slide. Bone healing happens in 2 stages, primary and secondary. Primary bone healing happens with absolute stability and compression. Secondary bone healing happens with 2 to 10% strain, so stabilization but not complete immobilization, and starts with callus formation in up to 2 weeks. Next slide. Reason why understanding this process is important is the development of modern plates has really had to take this into effect, in the sense that we're putting plates in for bony repair. We are combining biology and mechanics into one. With respect to a rib fracture and a plate construct, it is a race between bony healing and plate failure. Next slide. So you're really trying to optimize the biology and the environment for bony healing with that metal construct, which is not invincible. You need the bone to heal in the proper form for your fixation to be successful. So to maximize hardware effectiveness and minimize plate failure and non-union, a couple tips would be to make sure that your plates and screws are centered in the thickest, most robust portion of the rib. minimize dissection and stripping of the periosteum wherever possible. It's that periosteal inflammation that leads towards that secondary bone healing. And optimize strain within your plate. And what do I mean by that? Next slide. So most plates being titanium now gives you a specific material stiffness, but there are various plate thicknesses, which affects some of the pliability of those plates. Screw spacing gives you the option to space screws away from each other on a longer plate versus a shorter plate. Different constructs use bicortical versus unicortical screw configurations, which change strain in various ways. Your fracture gap is how much is left between your fractured ends. And working length is how long your plate is with specific respect to your screws. So longer plates with spaced screws spaces your working length. All of these things are optimizing strain on your plate, as in making those forces with every breath, every movement, every respiration, transmitting it across the plate and across the rib, rather than really stressing that gap where your plate is spanning a fracture. High strain on that gap plate construct will lead to plate failure. Next slide. So contemporary surgical options. These are a couple snapshots of a couple different options that are on the market today. Included this picture mostly just to visually see what the plates look like. They are small profile, low profile titanium plates with different ways to fixate them to the ribs. The majority of the plates on the market today use locking screws for fixation. There's a couple fixation options on the market that use intrathoracic rather than extrathoracic fixation. And there's one product on the market that uses unicortical rather than bicortical screws. Next slide. So for operative planning, where does that take us? Just to talk quickly on fracture taxonomy. This was released in 2020 with help with the Chest Wall Injury Society, with a goal to create nomenclature to improve clinical communication and standardized research, but really helps us to understand our fractures and our surgical planning. So next slide. And the outcomes of this paper was really 9 different lines. First line was that you need to categorize each of your fractures. Fractures can be categorized as simple, wedge, or complex. Next slide. Categorize the amount of displacement. They can be non-displaced, offset, or displaced. Next slide. The third point of the paper is that a series of fractures should be designated as such. If several ribs are fractured together, it should be designated as series. Also, the anatomical zones of the fracture need to be designated, anterior, lateral, and posterior being the 3. A costochondral area needs to be specified as well. A flail segment is noted in this paper as, again, we said more than 2 and 2 or more. And that it does also designate that there is a difference between a radiographic flail and a clinical flail, as we've already talked about. The approach to the chest wall anatomy with respect to the musculature depicted here, I want you to draw your attention to the triangle of auscultation, which is bounded by the trapezius, the scapula, and the latissimus inferiorly. And there's a little triangle of less musculature covering the chest wall there. And next slide, why I want you to look at that portion is because the bread and butter operative management approach that I wanted to demonstrate tonight is the keyhole approach. And this was really developed with the development of the most modernized titanium plates, because it is a minimized incision, muscle sparing approach, maintaining the integrity of the chest wall and the musculature. And because, next slide, it really approaches the majority of fractures that we see. So hot spots where we see a lot of fractures are really centered right around this lateral area. Next slide is another article demonstrating a similar process. Most fractures in the dark being demonstrated centered somewhere around rib 4 in the lateral aspect. So next slide. Should demonstrate a video for us showing, with a keyhole approach, a minimal incision somewhere in the range of 5 centimeters as designated by this video. An approach to the chest wall getting inferior to that musculature gets you below the latissimus, below the serratus and the scapula, below the trapezius, down to the chest wall, where you're able to visualize probably 4 or 5 rib levels fairly easily through this incision. So it's a super usable approach to the most commonly fractured sites. Next slide. But that's just one location on the chest wall. There are many other options to consider, which we really don't have time to go into a lot today, but just some considerations and some solutions that I'll just place in your mind. Posterior location has its own challenges. Being close to the costo-vertebral junction means that plate landing areas become sparse. So there are different solutions to being able to land plates really posteriorly. Excuse me. Beneath the scapula becomes challenging because approach with the scapula being in the way just makes working space difficult. Multiple rib fracture lines, i.e. multiple incisions to approach the fractures, involves a little more operative planning to just be mindful of your incision length in total. Rib contour, ribs are a little bit more contoured posteriorly. All of the ribs, all of the plates that we're placing have to be contoured perfectly to the rib for the appropriate tension. And some industry partners have pre-contoured ribs, which may help in timing in the operating room. Pleural space complications. If you have a patient with a hemothorax, with a diaphragmatic injury, or other reasons why you might need to be in the chest, this may be an opportunity to do repairs from a VATS approach as well. So I mentioned there are some industry partners that give you that option if you're already in the chest. Costochondral involvement. I did see a question in the chat pop up briefly. I did mention that the chondral space needs mentioned specifically separately from the rib sites, as I mentioned from that paper, which means there do need to be specific plans for addressing complex costochondral involvement fractures as well. Comorbidities, patients with other pulmonary comorbidities may have challenges for getting to an operating room with single lung ventilation, so that may change your approach, whether it be extrathoracic versus intrathoracic. And the last point here is your planned analgesia, which may be again, intrathoracic versus extrathoracic application may affect your decision making. Next slide, please. So key takeaways from this last portion. Adhere to basic principles to optimize bone healing. It's your best chance for success. Fracture taxonomy may steer operative planning. And last point I want to say, just to demonstrate the multiple industry partners that help us take care of these patients, no head-to-head trials from any of these different products that are out there. Do what you do, or what you're allowed to do by your hospital. Do what you do well, and take some of these principles to heart. So thank you.
Thank you, Dr. Wolf. That was great. I see Dr. Malat, who's the chair and obviously well known to us in trauma, asked a question, which I think is great. And he asked about posterior costovertebral fractures, which in my experience, sometimes they may look broken, but they're still pretty fixed. In other words, they don't move. So should they get titanium, as orthopedic would have us advocate, or is it a kind of case by case? What do you do?
Yeah, I would say it's case by case depending on how posterior we're talking. So depending on the plate construct you're using, you need a landing zone to get a plate, number one. But we also know through the literature that the posterior fractures are most likely to displace over time. So that first image may just be a snapshot in time of the displacement. So if there's any question, maybe repeat imaging in a short interval to see what the fracture burden really looks like. That would help me a lot in decision making.
Great answer. All right, we're going to move to another big part of this, which is Dr. Jack He is going to speak to us. Dr. He joined us in the past year from Arizona, did his fellowship at Pittsburgh, and will be talking to us about adjuvant pain treatment at the time of surgery. Obviously, we could have hours on this alone. Dr. He, you're on the floor.
Perfect. Thank you for the introduction. Okay, as far as disclosures go, in the full spirit of full disclosure, I have attended training sessions hosted by Adjuvant where meals were provided. I think it is not uncommon in the line of our work to, back up one more. Today, we'll quickly highlight some of the analgesic options for risk fractures, focusing more on the newer techniques that we can provide as surgeons and their outcomes. It is not uncommon in our line of work to see, the 3D recon of a chest that look like this in our trauma patients. So, of course, we prescribe our entire arsenal of oral and IV analgesic, but unfortunately, the patient is still very much in pain. So what's next? What options do we have as surgeons? So this picture highlights some of the regional anesthesia blocks that are available to us, however, and also based on their location of block. But today we will only focus on the myofascial plane blocks, since they have been reported to be safely done by us surgeons and also emergency medicine physicians in the emergency room. So they consist of the erector spinae block and the serratus anterior block. In the erector spinae block, local anesthetics is instilled between the anterior surface of the erector spinae muscle and posterior surface of the spinal transverse process, which then diffuse into the paravertebral, epidural, and intercostal spaces. This provides coverage of the posterior chest wall to mid-axillary line typically, but may actually cover some of the anterior chest areas, and they tend to span over 9 dermatomes, which means this should work well to cover not only lateral risk fractures, but also posterior risk fractures. The reported successful rate for this modality is 78%. For the serratus anterior block, the local anesthetics is injected into the space between the serratus anterior and latissimus dorsi muscles, or if you do a deep block, it's injected underneath the serratus anterior muscle. And this blocks T2 to T9 dermatome and covers the anterolateral hemithorax, of course, in a unilateral fashion. So it may not work so well to cover the posterior risk fractures. And however, due to patient injury pattern and inability to position, you may not be able to do any erector spinae muscle block. And this is sort of the backup for that. The reported success rate is 86.4% for this modality. So known complications of these blocks include inadvertent motor block, pneumothorax, and intravascular injection. But they occur very rarely. 2 out of 10,000 cases were reported for the erector spinae block, and 0 out of 875 were reported in a meta-analysis for serratus anterior block. So how well do these regional anesthesia modalities actually work for our risk fracture patients? So in a meta-analysis performed by a joint venture between the Eastern Association of Surgery for Trauma and the Chest Wall Injury Society, there was actually no recommendation that could be made for or against the use of regional anesthesia due to lack of evidence. But contrastingly, a meta-analysis of 27 randomized controlled trials consisting of over 1,500 patients was published earlier this year. And in this study, regional anesthesia was compared against IV analgesia. The authors were able to show that different regional anesthesia modalities were was associated with lower pain scores, less analgesic doses at 24 hours, shorter hospital length of stay, ventilator days, and also ICU length of stay. So moving on to procedures that are mostly done in the operating room, the first two are likely to be familiar to many of you. The intercostal nerve block involves injecting a local anesthetic under the rib to anesthetize the intercostal nerve. Typically, if this is not done in the operating room, of course, all levels of the rib fractures are blocked, including one level above and below the extent of injury. Again, like I said earlier, this could be done at the bedside or can be done intraoperatively during VATS. Alternatively, I think a lot of us are familiar with tunneling in a continuous infusion catheter in the subcapsular space via our surgical incision. Another modality described by Truitt et al. Actually involves inserting a paravertebral infusion catheter, and this can be done in the operating room, but also done at the bedside. So specifically, an infusion catheter is tunneled one intercostal space below the lowest rib fracture, about 3 to 4 finger breadths lateral to the spinous process, and in a plane just superficial to the ribs. It's been described that you can do this anatomically, but in my hands, I would do it under ultrasound guidance. How well does this work? So retrospective studies have reported that this technique is associated with lower pain score at 60 minutes post-procedure, increased maximum inspiratory volume, shorter hospital length of stay by 3 days, more hospital-free days at 30 days and 90 days, and even lower mortality. But again, these are only retrospective single-center studies. Lastly, we'll discuss intercostal nerve cryoablation. Even though this modality has been used in thoracic and pediatric surgery, it is relatively new in the world of chest wall injury and has been gaining popularity. Mechanistically, in this procedure, the intercostal nerve is frozen to -40 to -70 degrees centigrade by a probe to cause axonal temesis, which means the axon and the myelin sheath are destroyed, but the periaxonal structures are left intact. And of course, if you recall from all the way back in medical school, this is followed by Wallerian degeneration and new generation as the axon heals itself at a speed of 1 to 3 millimeters per day. So this process theoretically translates into an analgesic effect that can last 6 to 12 months. So from a technical standpoint, the cryoablation probe is placed on the neurovascular bundle, approximately 4 centimeters from the thoracic spine, or 2 centimeters from the costal vertebral junction to avoid damaging the sympathetic chain. Then a 2 minutes freeze thaw cycle happens, and this is of course done for all rib fractures, including one level above and below the extent of injured ribs. A word of caution. The FDA only approved this technology and modality to freeze intercostal nerves 3 through 9. If we freeze above that, you may damage the sympathetic chain and cause Horner syndrome. And if you freeze below, you may get pseudo hernia. Some contraindications. This procedure should not be used in patients with coagulopathy or cold hypersensitivity disorders. How well does this work? Well, there's very much a paucity on the evidence. I only saw 5 retrospective studies. With that said, when rib fixation is compared to rib fixation with cryoablation, these studies have shown that both groups had similar operating time, the duration of operation, excuse me. Cryoablation group had similar, if not shorter, hospital length of stay, ICU length of stay, similar or lower opioid use, lower hospital charges, and less in-patient complications such as pulmonary embolism or a VAP. 2 of these previously mentioned studies reported complications. One of them mentioned 6%, so 1 out of 19 patients had mild lateral chest wall paresthesia at 6 months. And then another study basically reported that there were lower minor complications rates in the cryoablation group in 3 months, and they defined lower minor complications as surgical site infection, delayed wound healing, pneumothorax, small pleural effusion, and seroma. So contrastingly, in thoracic surgery, a randomized control trial that was actually just published a few days ago, they looked at the effect of intercostal nerve block versus cryoablation. The authors reported that the incidence of neuropathic pain as reflected by the Lance score were higher at 3, 6, and 12 months after cryoablation. And these cryoablated patients actually had higher pain scores at 3 and 6 months.
That's
So
fascinating.
in summary, there are several modalities for pain treatment for rib fractures. However, the quality of evidence, as we've seen, is still very poor, and more research is definitely needed. I think based on that, an informed discussion with the patient and the family is absolutely necessary, because we really don't have long-term outcome for these modalities. However, I will say that the best analgesia plan will probably entail a personalized approach by incorporating patient factors, injury pattern, and involve multiple disciplines using different analgesic modalities. Thank you.
That was fantastic, Dr. He, and very important, because I think there's a lot of data we don't know about these modalities. And there's no clear winner, as you said. Moving along, we're going to close out the presentations with kind of looking at really where we headed with all this. We certainly made a lot of progress in the last 10 years, but there's certainly some really cool new technology coming out, and there's no better person to talk about that than Dr. William Lukart. Dr. Lukart's, again, another trauma critical care surgeon in Akron, level 1 facility with Cleveland Clinic, and I've known Dr. Lukart for a long time, and this is right up his alley. So Dr. Lukart, take it away.
Thank you very much. It's my pleasure to join this august group and chat about something I'm extremely passionate about. So we're going to go from sort of where we live in reality right now to where we can be, and where hopefully we will be in the not so distant future. I have nothing to disclose. So yeah, I think to really appreciate how these new technologies can help us, let's take a look at where we're at right now. So you've seen some of our different ways of fixing the ribs, the planning, the assessing, of addressing pain control. So currently, if we have a patient that comes to us as a chest wall surface evaluation, we get the thin slice CT, we get the 3D recons. The 3D recons will look something like this. We have multiple static views. We need anatomic reference points, and we'll also use physical exam. In this particular instance, this was a male in his early 50s who'd been run over multiple times. The individual axial slices of the CT won't give you quite the full impression and picture of this, that actually looking at these 3D reconstructions in different views well. As you can see here, looking from the top down, he actually has his second rib, which is plunged down into his right upper lobe. And pretty much anywhere on this chest we make an incision, certainly laterally, we're bound to get to the fracture. The anterior portion is a little bit more complex because, as was mentioned in the chat, you have considerable dissociation of the costochondral cartilage and frankly terrible disruption here. So in this instance, making the incision in the proper place is important, but you're making two separate incisions, and you're going to have a lot of connecting incisions as well. In this instance, when we do sternal plating, we measure from known landmarks. I use the spine as a reference for our rib plating, but we can measure from the scapula, from the spine. We can also measure from the sternal notch. The simplest version of how we actually do our operative planning is a midline structure with a fixed width with fixed distances. In this instance, we can measure down from the top of the manubrium. We can go to the manubriosternal junction, and we can very precisely between the sternal notch and the xiphoid place our incision exactly where it needs to be and dissect down to it. These are both instances of unstable fractures. One is a male in his 70s that had this steering column. The other is a Miller's 20s, which has a significantly displaced fracture. Yeah, we don't always have the luxury of those beautiful CT 3D reconstructions that we saw initially, and this also takes into account both the curvature and the distance for our plating. So many times what we use as our fixed landmark is we'll measure from the spine, we can add the distance from the midline spine to the transverse process, and make sure we have enough, as you can see from our little table here, enough landing zone to place our plates posteriorly. As you can see, the image is not nearly as clean. I've superimposed these labels, but these labels also help you when you're working as the captain of the team in the operating room, trying to fix these. Also with your plating reps, trying to help provide the correct plate for the correct level. But this helps with incision planning. You can use both physical exam measurements, but also in this instance, ultrasound localization to make your incision precisely over the fracture is helpful. So how do we innovate? We extend our reality. Extended reality is a spectrum. It's not a binary concept. It goes from the physical reality that we're used to all the way on the other extreme to virtuality. So augmented reality is where we superimpose virtual reality onto real world environments. The other end of that continuum is the virtual reality, where we visualize and explore using 3D generated computer environments. This is the sort of a 3D reality that we can appreciate. This is where a CT is obtained, 3D reconstructions and models are used, the 3D print is actually generated, and this is intended to help with better appreciation of spatial relationships and aids in surgical planning. This is primarily of benefit when you have extended time from preparation, when you're not trying to get in a 48 to 72 hour window. The advantages of this are exemplified by some of the vendors in the pre-bended plates. You can ensure better fitment. You can actually create a model, adjust your plates to what your specific needs are, such that when you go to the operating room, you have pre-bent, sterilized plates that you just make your incisions, get down to your particular rib level, and you'll also know that your fitment and your holes will line up and be precisely aligned over the fracture. The other version, which goes a little bit more on the fringe with this, certainly for what we do in trauma right now, is the potentially 3D printed or titanium ribs. This would be a potential use case when the rib is so utterly destroyed that you're trying to figure out how you're going to actually give it some strength, some rigidity, and how you're actually going to put screws or plates in anything, plus or minus cerclage. Another version, which I think is slightly fringe, but in relation to the costochondral question, is the 3D printing offers the opportunity for a Greek wave or spring-like modification. So this would allow an opportunity for us to mimic the native chest wall physiology, give some flexibility to the sternocostal junction, but still maintain the flexibility of the chest wall that we're used to for breathing. Different ways of generating these models would be the standard 3D printing that most folks may have in their basement or their garage or what room in their house. These all take time to build, and in a time-intensive environment such as our trauma settings, the hours to days is not the luxury that we have. Continuous liquid interface production would let us do something that's more akin to 3D laser printing in real time, which would give us a workable model. And obviously the titanium printing is certainly going to be longer than either of those methodologies. The one thing I will mention that is very unique and hopefully a future pathway for rib plating is the titanium are light, strong, and they can actually be used to provide basically a substrate for bone ingrowth down the road. 3D printing trade-offs. It can help make your intraoperative time far more efficient, give a custom fit. There's diminished waste because you have a single custom built product. The downside is more time and planning is involved. There's time for model development. That is very expensive, both from a human resource standpoint, but also the cost for printing and materials. Printing time is not inconsequential, and it is of very little value, unfortunately, in urgent cases. So if we were to apply it in these instances, the 3D model would certainly help with the time bending. So with a 3D model, you could potentially see how you could adjust these ribs to fit to make sure you had appropriate plate lengths, the appropriate plate contours, and you could have a physical model to adjust what you're trying to set up here. It could also be useful if we were trying to restore chest wall physiology. As you can see, this huge costochondral separation really doesn't give us a good anchoring point, because all of these would actually have to sit in cartilage alone. So in this instance, we actually had to bridge from the ribs, where we had substantive rib, all the way over to the sternum.
And Will, you just used a titanium plate to bridge that at this point in time, because that's really, you either don't do it, you're going to cartilage, or you use the titanium plate to bridge that. Is that correct?
That is absolutely correct. This gentleman, when we actually did a parasternal incision, as soon as we split down to his pec, we just saw the lung sitting right in front of our face. So yes, the unfortunately for this gentleman, there's so much disruption, we actually had to use a very long titanium plate. Correct. Yeah, in this particular instance, this is where we're starting to go from the physical to the extended reality. This is a unique specific system. The QR code will take you to their website, and this is something Dr. Claridge has used as well. This is a multi-step process too. Not necessarily super clean, but getting more efficient in time. We start out with our CT DICOM image. The advantage of this is we can do the immersive virtual reality planning. So with the luxury of a bit of time, you can piece together and plate out what it is you're going to do. You can, in essence, rehearse your operation before you actually get into the operating room, and often troubleshoot problems. After you do that, the VR planning, you can transition to the immersive, augmented reality headset, and then when you take that into the operating room context, it gives you tremendous advantages for incision planning, as we'll see here shortly. So with the virtual reality planning, you have high definition visuals. So if somebody has poor bone density, you can adjust based upon your Hounsfield units up or down to specifically parse out the bone, specifically highlight the cartilage, or see the relationship to the diaphragm. You can adjust your layers, and you can very precisely measure distances in a way that the measuring on your current 3D reconstructions doesn't necessarily allow. The other thing which is really fascinating and amazing is that you can use this to create basically Legos or the fixable components that you can use to basically do your entire surgery here. So in this instance, the colored segments you see here are the different rib fragments, and this particular individual has a fairly nasty set of fractures, which are going to require bridging plates. You can basically do a rehearsal for your surgery in a virtual setting. This is Dr. Claridge prepping for one of the patients. In the middle, you can see the segments with which he's going to plate. But in this instance, you also see the scapula is cut out. Obviously, the scapula is not cut out for the real individuals. This actually shows your QR codes, which are your reference points. Your reference points are usually spine, around C7, your sternum, sternal notch, xiphoid, and nipples. This lets you do your rehearsal as Dr. Claridge was here. Let's see if this will play for you. So this is a real-time walkthrough of our incision planning on a real trauma patient. This individual, as you can see, has those QR codes which maintain the visual reference frames. Once the augmented reality overlay is set up, you can pick the edge of your costal margin. You can see where your fractures are. You can cut down very specifically over those locations. This is extraordinarily helpful for folks that have thicker chest walls, thicker back, the fractures that aren't palpable. This is very advantageous because many of the older, thinner individuals that are more emaciated, you can see your entire incision line basically as a precipice or shelf that falls off. But individuals with thicker chest wall, you can use the time less efficiently and struggle to find exactly where you need to go. This does require a good bit of radiology support for processing time to generate your 3D reconstructions and models. Pushing the data back and forth does take time. You do have to have fixed reference markers which are maintained within the frame, and this can become a little bit more challenging when you're actually operating. So this is helpful for the pre-op, but not live mainstream with using it while you're sterilely prepped. it does allow excellent simulation of the operation. So who actually uses this extended reality? The orthopedic trauma surgery has made considerable inroads here. There is a paucity of data in this sphere, so the potential is limitless at this point. It helped them with surgical planning for complex fractures. They did it with 30 fractures, randomized, and had a highly significant shorter operative time. This, I think, exemplifies the difference between the 3D reconstruction and how the augmented reality can help. Because in pane A, you actually see the thin slices, axial, coronal, sagittal, that don't really give the fullest representation of the fracture in the same fashion that the pane B does, which in all of these panes, you actually see how complex that fracture is and how difficult it's going to be to reorient all of those slices. The immersive 3D or the virtual reality has been well demonstrated in the oncologic thoracic world to actually help with better precision for resection and also better substitutes for chest wall planning. The difference between virtual reality and CT, even though the CTs are high resolution, was significant in planning your resection more clearly. In addition, your need for a chest wall substitute was highly significant. So when do we use it? We use it for preoperative planning. It is helpful for procedural simulation as well as working with trainees. If your case volume is lower, this presents an opportunity for you to go through the rehearsal of actually doing the chest wall reconstruction, although you may not actually have the numbers at your center. It certainly supports refined preoperative strategies, so we're more efficient with our plates, which one we're using, the fashioning and bending. It helps our resource management. Intraoperative, it makes us far more accurate. We don't rely on just being within a few centimeters. We can actually be far more precise than that. And ideally, this helps our patients because most of these folks have severely deranged pulmonary physiology. So you're working on a fuse that is burning much shorter while you're operating. So if you can do more of your planning beforehand, you can significantly diminish your operative time, and the chances of you either staying intrathoracic or having more time on single lung ventilation is much better. So you can certainly impact postoperative outcomes with this. So three key takeaways from this. The 3D printing and models and prosthesis hold promise for improved outcomes and planning. The augmented and virtual reality can improve the accuracy and shorten your operative times. And the extended reality space is expanding exponentially and is at this point virtually limitless in how we can utilize it. Now back to you, Dr. Claridge.
This is great. So I think the big piece for us is, we're trying to advocate doing this within 72 hours, maybe 4 days, but we try to get it done by 3 days. And I think we're not quite there yet with some of the technology. How long do you think it'll be before we can actually get these, augmented reality, which is, I think, the way we're going to go with this to really help us plan our incisions? How long away till we can get it done within 24 hours so we can have that information at our fingertips?
At our current rate of progress, I would estimate within the next year or two, it's something that we could really move a lot more mainstream. With the explosion of AI technology and the quantum and cloud computing, our capability to do that is really within the foreseeable future.
Right, and we have a couple cases, but I think we'll avoid those. I think we could talk forever. I think I'll ask a couple questions that we kind of seen come through here. One, we talked about the costal cartilage, kind of the cartilage problems. So I think we've talked about that. I think there are other times where the rib fractures become dangerous as they injure other organs. I've seen liver, I've seen the heart, I've seen the aorta. So we obviously will fix those at the same time, but obviously the bleeding organ comes first. So I think those are keys. One of the questions that I'd like to ask the panel real fast, and so there's this debate in the literature, which isn't answered, and I've seen it take both sides. Someone's got 4 or 5 rib fractures, 3 or 4 of them are significantly displaced. Do you need to fix every fracture? I'll start with you, Dr. Beams. What have you seen in the literature, and what are your thoughts?
Yeah, I think that focusing on the most severely displaced is the priority, and usually those are in a single fracture line. So I think you have diminishing rewards if you have to make multiple incisions to reach the fractures.
Dr. He, your thoughts on that?
I think that it's a little bit caveats, right? So the 11th and 12th rib, I think no one's going to touch that, or the first and second rib. As far as all the other ribs, if you have a flail segment, I think there are various societies that have statements that say you should be trying to fix both fracture lines. But I agree with Dr. Beams. I usually go after the most displaced ribs. However, if I'm there and the patient is symptomatic, I will tend to fix everything that is displaced.
Fair. Anything to add to that, Dr. Wolf?
I would just add, if it is a flail segment, I do attempt to address both segments whenever possible. There is a lot of data showing, like you said, do you have to fix both segments? Do you have to fix every rib? I think it is a case by case, but if you can get to both, if your incision gets you to both, and you can address the entire situation, then do it.
Yeah, and then there's kind of getting with that, there's different techniques coming out. Not drilling and putting screws in is kind of moving. I think that's advanced. You can make a sandwich to kind of hold it firmer, as well as to use a combination of plates, or do you use one long plate? Will, what are your thoughts on that?
Yeah, I think some of it has to be weighed with the morbidity of actually getting to the fracture. Some of the particularly anterior or high fractures are going to burn up a lot of extraoperative time. And while you may be able to dissect through the pec or drill through the scapula in places, you may not get as much benefit from that for what it takes to actually get there. But yes, I think sometimes you have to use the long plates to have some relative degree of stability.
All right, I'm going to close this with one last question. And I will say this is a team effort. Often, I think we talk to each other about the patient quality, the comorbidities, et cetera, et cetera. So Dr. Malat asked you guys, how do you make sure you can get that patient within the OR within 72 hours? Is it arm wrestling? Is it who's on call? Do you have a call team? Can you tell me a little bit about that, Dr. Wolf?
Yeah, so when we rolled out our center as a chest wall center, it was initially myself, then Dr. Lukart and Dr. He and some other surgeons that were helping take that load. So initially, when I took that on, it was, I personally said this is important to our patients, and that meant that I was taking care of those when they needed done, regardless of when it was happening. So it takes some ownership on the service, assuming care of these patients for sure.
I want to thank our panelists. It's time to wind down. We have about 1 minute left. Again, great topic, a lot of interest. Hopefully we get invited back where we can really show some cases and some neat things that we can do for patients, because I think if you've seen one of these patients post-operatively, you see them do extremely well. And I think that that's kind of a big take-home message. Live from Cleveland Clinic is December 10th. That's the last one for this year. Everyone log on. We can talk about esophageal disease. So thank you very much. Again, I want to thank everyone for their time, and reach out to any one of these people on the screen today. We're happy to talk anytime. Have a wonderful night. Thank you.